I'm a research fellow at the University of Glasgow, and I have been involved in the update of the Developing and Evaluating Complex Interventions framework, which was funded by the Medical Research Council and also the National Institute for Health and Care Research. So as Martin said, I'm going to give a bit of an overview of the document, but first of all, I just want to provide some insight into why we updated it and a little bit of background on the history. So the original document was published in 2000, and it was largely about providing rigorous methods for evaluating the effectiveness of non-pharmacological interventions. It talked about complex interventions of those that are made up of various interconnecting parts, and it was largely focused on randomized controlled trials in terms of evaluation. The 2006 document, you might hear me refer to it as 2006 or 2008. It was published as a report in 2006 by the Medical Research Council, but then published as a paper in the British Medical Journal in 2008. So it was much less linear and more flexible than the 2000s version. And it took into account intervention development and implementation rather than just evaluation. So it did expand from trial-based evaluation design to incorporate more natural experimental studies too. And then the update last year took that a little bit further. So you'll find out a little bit more about that in a second. Okay, just to make sure everybody's on the same page with what we're talking about when we say intervention. The definition that we've used is an action or program that aims to bring about identifiable outcomes. So it's a fairly broad definition, and we're using it to think about everything from medical treatment. So it could be a change in surgical procedure to changes in policy, for example, a change in welfare policy that might have some impact on health. So it could be developed and implemented by the research team, or it could be something beyond the researcher's control. And here, given our funding and our expertise, we focus on things that might have some impact on health, but potentially could be applicable more broadly. So why did we update the framework? There were various reasons that we updated the framework that are written here. And this is largely how I'm going to structure the presentation. So I won't read these all out just now, but I'll give a little bit of detail on each one and what we ended up doing about it. So there were various theoretical and methodological developments since the previous version of the framework that we wanted to incorporate into this document. And it was clear that the guidance, the original guidance, and more so the 2008 document was very well cited. So you can see here that the citations for the 2008 BMJ paper have continued to rise since 2008. I think the last time I looked at Google citations, it was over 10,000 citations over the course of 10 to 15 years. So this has been used in, or referred to at least in funding applications and papers. But it was becoming clear to people in the Medical Research Council and elsewhere that there were various criticisms of the document, largely related to developments that had gone on since it was published. So a team of us set about the update, and we went through various steps to get there. We did a gap analysis, which was a literature review around each of the sort of broad topic headings that we felt had been developed or had some form of development since the previous version. So we had a literature review on that, which also took into account documents that had been, or papers and academic documents that had been critical of the framework, to try and pull out what those criticisms were. We then took this information to an expert workshop that we held in London pre-pandemic with around 40 experts. From there, we drafted our first version of the document and put that out for open consultation. So that was a web-based consultation, and we received over 50 very detailed responses actually to that, and that really fed into the next draft of the document. We had various rounds of peer review with the NIHR Journals Library, and then laterally with the British Medical Journal. And this was all overseen by a scientific advisory group. So the first reason for the update was to update the definition of complex interventions, in particular highlighting the relationship between the intervention and its context. So I just want to go back again to the 2006 document, which talked about a complex intervention as being about interventions that have various interactions between components within the experimental and control interventions. Another dimension of complexity is the number and difficulty of behaviours required by those either delivering or receiving the intervention. The various groups or organisational levels targeted by the intervention, the number and variability of outcomes, and the degree of flexibility or tailoring of the intervention permitted. So these were largely, when thinking about dimensions of complexity, these were largely about the intervention itself, possibly with the exception of the final one, but mostly the complexity was kind of discussed as part of the intervention. So we wanted to broaden that out a little bit, so not get rid of anything that had already been said, in that the characteristics of the intervention itself do indeed bring some complexity, but we wanted to also talk about the interactions between the intervention and its context. And each of these things is important for considering how we should evaluate the intervention. So when I talk about context, I'm talking about any feature of the circumstances in which an intervention is conceived, developed, evaluated, and implemented. And as I'm sure you've all considered, effects of an intervention might be highly context dependent. And context is dynamic and multidimensional. It might relate to social context, economic context, political context, etc. I just want to give an example of an intervention that under the previous definition of complex interventions would have been seen as very simple. So this is the lucky iron fish, the picture on the right. It's a small iron ingot that's placed in cooking pots as a way of preventing dietary anemia. So a bit of the iron is expected to leach into the cooking water, and that can reduce dietary iron deficiency. So like I said, under the definition of complex interventions previously, this would have been seen as fairly simple. It's got no moving parts. It doesn't seem to require complex behaviours. But if you actually think about the whole process of manufacturing and supplying the fish, encouraging people to use them, plus local contextual factors that could interact with how the intervention works, it does become fairly complex. So this is just a very straightforward logic model for the intervention. The problem was endemic iron deficiency. The intervention was the iron fish, and then the expectation was that this would lead to increased iron intake and reduced anemia. So the intervention was designed originally for rural Cambodians, where the fish could be produced and sourced locally. And the fish shape was also used to increase uptake, because fish are widely considered to be lucky in Cambodian villages. So these are various things that are likely to lead to, or likely to work in the favour of the intervention. And although some trials have shown that the fish have been effective for reducing iron deficiency anemia, other trials have actually shown no effect, and that's been later been found to be because anemia in these regions is primarily due to genetic hemoglobin disorder rather than dietary iron deficiency. So the cause of the anemia was obviously not necessarily considered in the intervention when transferred to those other contexts. And other contextual factors might also be important in determining effectiveness. For example, the capacity to manufacture fish locally and cheaply, the cultural meanings of fish, the household cooking and storage practices, and obviously the causes of anemia, which are not all dietary. So hopefully that just highlights the importance of context in a reasonably straightforward way. So the second reason for our update was to shift the focus to the usefulness of evidence as the basis for determining the research perspective and the research questions. So again, just going back to the original document, which is now over 20 years old, this was published in 2000, and it really arose through a translation of the types of framework that were used to guide drug development research. And then it was adapted to be fit for evaluating more complex interventions in public health and health services research and healthcare. It remained within a sort of central paradigm where the cardinal question was, does the intervention work? It was focused largely on unbiased estimates of effect in terms of evaluation. So you can see the phase 3 here on the top left is about having a definitive randomized control trial. So there wasn't much room for different study designs beyond that. In 2006, like I said before, it was much less linear, and it moved from researcher developed interventions to consider interventions more broadly. And it was still largely about effectiveness when it came to evaluation. So you can see under the evaluation box, there's a bit on assessing effectiveness, and there's also a bit on understanding the change process, where they talked a bit about process evaluation. But I think that was sort of very early on in those sorts of discussions around process evaluation, and they couldn't really go into too much detail there. So we know that many of the most promising interventions either don't get or can't be evaluated in that way with a randomized control trial. If you think about service and policy and innovation and population level policies, and even if they can be evaluated in that way, and are shown to be effective in a controlled trial, that's not always replicated. Sometimes they're not implementable, or implementation failure occurs. They may not be transferable across contexts, and also wider system effects might emerge. So if it's shown to be effective in the short term and then implemented, the effects might be washed away or diluted because of system change. And this is particularly evident in interventions tackling so-called wicked issues like obesity, where the system of influence is huge and where a small change to one aspect is very unlikely to make much of a difference in the long run. So there was said to be insufficient attention paid to what happens after an intervention has been evaluated. And it became clear that resources and investment were not necessarily optimized, leading to research waste, or a production line, if you like, of researcher-led effective interventions that are limited in terms of implementation requirements and stakeholder insight, and that generally don't work. So Doug Altman, who advocated for a change in methods and reporting, stated that we need less research, better research, and research done for the right reasons. And we wanted to reflect a bit on that in our new framework document. And to do so, we wanted to emphasize the use of diverse research perspectives. So we came up with these 4 different perspectives from efficacy, effectiveness, theory-based, and systems perspectives, which all answer slightly different questions. So a key point about this framework is that it's flexible to research needs. It takes a pluralist approach. So our idea was that the research perspectives should guide the design and conduct of the complex intervention research. And what we really wanted to do was to encourage wider awareness, understanding, and use of research that gives sufficient and appropriate consideration to different sources of complexity. And sometimes it might be entirely appropriate to control for that in an efficacy or effectiveness perspective, but it won't always be the case. So just to highlight that we've laid these perspectives out as being overlapping rather than mutually exclusive, and the choice of research perspective should really be governed by the research questions that you want to answer. So although we haven't explicitly discussed epistemology, we have challenged that view that unbiased estimates of effectiveness are the cardinal goal of evaluation. Excuse me. But we largely take a pragmatic approach, whereby we have encouraged researchers to take the most appropriate approach to generate the new knowledge that is likely to be useful to the problem being targeted. So I'm just going to go through each of these perspectives a little bit. Excuse me. So the efficacy perspective is an explanatory approach to test causal hypotheses about the outcomes generated by the intervention. It's about testing whether the intervention can work in an ideal situation. It aims for high internal validity, controls for contextual variation, and is usually based in sort of idealized or controlled conditions. So one example is if we're thinking about a behavioral intervention, under an efficacy perspective, it might be that the nurse practitioners who are delivering the intervention have received intensive training to deliver the intervention. And the individuals who are receiving the intervention might have identified themselves as being very motivated to engage. So it's in that situation, there's a sort of idealized condition. It's not exactly how it would be in practice. An effectiveness perspective is similar to an efficacy perspective. So this is also about testing causal hypotheses about the outcomes that are generated by the intervention. But here, the intervention is tested in the settings that the intervention would be delivered in practice. So for example, if we carry on that behavioral intervention example, the intervention would be perhaps delivered by nurse practitioners in a random sample of primary care centres within an area to patients who are referred on to their family doctor rather than necessarily who volunteer themselves immediately. And I think this was probably what most research, the perspective that most research took up to a point, particularly before various strands of theory-based evaluation was. Sorry, my slides are just moving by themselves. Before theory-based perspectives were more common. So moving on to theory-based perspectives. So there are various theory-based evaluation approaches within different disciplines: social science, health sciences, international development. And they really seek to identify the underlying theory or mechanism of an intervention. They're still underpinned by causation, so they want to understand causation, why things work in the way that they do. So causation is still very much at the heart of most of these approaches. And developing, testing and updating program theory is one of the consistent threads through this sort of family of theory-based approaches. So they're looking for causal connections between activities and outcomes, either intended or unintended, and theorizing these links and trying to explain them. So when I talk about program theory, I'm talking about, well, program theory describes how an intervention is expected to lead to its effects and under what conditions. It articulates the key components of the intervention and how they interact, the mechanisms of the intervention, the different features of context that are expected to influence those mechanisms, and how those mechanisms might influence the context. There's different evaluation approaches that kind of fall under this theory-based perspective, like theory of change evaluation, realist evaluation, process evaluation, etc., as well as various different terms used for what I've just described as program theory. It's often used interchangeably with theory of change and sometimes logic model. In our longer NIHR Journals Library document, we included a glossary which tried to be transparent about what we meant by each of these terms. That can be a little bit confusing. There is some debate about whether the different approaches to theory-based evaluation are necessarily compatible with other perspectives. For example, whether it's possible to have realist randomized control trials, and whether systems perspectives and realist perspectives can overlap or not. And I think that's really down to individual perspective on those matters. But if you're interested, there's various kind of debate articles that go into that in a bit more detail. I think the key message from us was that we were taking a pluralist approach and felt that that these methods could be, that these perspectives could overlap. So thinking about a systems perspective, we can theorize interventions as events within systems. A system is a set of things, for example, cells, people, organizations, etc., that are interconnected in such a way that they produce their own pattern of behavior over time. Systems thinking can help us to understand the interaction between an intervention and the context that it's implemented in a dynamic way. Largely, I think it encourages us to think more about the bigger picture, so how interventions can impact on different parts of the system, sometimes in unexpected ways through system properties, which I'll talk about in a second. So outcomes emerge from the interaction of the parts of a system in ways that can't necessarily be predicted from the properties of the individual parts. So hopefully saying more clearly, a system can't be understood by breaking it down into its individual entities and then studying each part separately, because they're so intrinsically connected to each other. So there's various different examples of system properties that help explain why we can't think of complex interventions as discrete entities. And these are just a few on the screen here. So systems in which interventions are implemented constitute lots of different kinds of parts, not just individuals and all of their various differences, but individuals that interact in different ways with organizations, institutions, networks, natural and built environment, etc. And they are heterogeneous. So I'm not going to give examples of each of the system properties, but I will just give an example of adaptation. So adaptation is how the system responds to change. Asks the question, does an intervention or event prompt people to do things differently, and does that lead to other changes in the system? So one example is the ban on multi-buy offers of alcohol in Scotland. So this is a policy that was introduced, which meant that retailers couldn't offer discounts on multi-buys. For example, they couldn't offer 3 bottles of wine for £10. But what actually happened was that retailers adapted to that by offering more promotions on individual items. So for example, rather than 3 bottles of wine for £10, the prices were reduced on individual bottles. And this was actually before Scotland introduced their minimum unit pricing policy. And I think that further highlights the need for thinking about a combination of policy approaches to come together in a strategy that takes account of the whole system, because retailers will now be more limited in terms of reducing the price on individual items as well because of the minimum unit pricing policy. And as such, Scotland has an alcohol strategy that to some extent does take a systems approach to the policy development. So there's been lots of talk about systems. Back in 2017, Harry Rutter and colleagues published a paper in The Lancet which said rhetoric urging complex systems approaches is only rarely operationalized in ways that generate relevant evidence or effective policies. And I think when we were developing our framework, that was largely still the case. I mean, it was only a couple of years later that we started this work, that there weren't loads and loads of great examples that we could draw on for taking a systems approach. So what we were really wanted to do was just have an acknowledgement of complexity. So encouraging people to approach interventions with a systems perspective can encourage them to develop research questions that take into account this sort of wider contextual factors that influence the intervention. So in acknowledging complexity, it doesn't mean necessarily that all research has to explore all aspects of it. But by thinking about it, it can support the development and evaluation design, particularly I think, through identifying the key uncertainties surrounding the problem or intervention and the questions that we might ask of it. It can also support the interpretation of the data, but it doesn't really neatly fit into the sort of effectiveness and randomized controlled trial paradigm. And I think there's still some to be done to provide these good examples and to support others to take this perspective. But taking a systems perspective, as I said, can change the focus of interventions. So if we think about targeting individuals with interventions to bring about behaviour change, rather than doing that, we might, by taking a systems perspective, think about upstream action to create the conditions or the context, the relationships that support the behaviour change. And similarly, rather than one-off interventions, we might think about systemic, sustained change in schools, workplaces, policy, hospital, etc. culture. It can also change the focus of the evaluation from considering whether the intervention is effective to whether it contributes. So thinking about what works to what contributes to the system in a positive way, from attribution to contribution. And whether an intervention contributes could take a systems-based approach or a theory-based approach, or even tailor the traditional effectiveness approaches to usefulness. Could even sort of tailor the traditional effectiveness approaches alongside one of these other perspectives. So the key questions here are: how will the research make a difference? Who will use it? And who will benefit from it? So these are the 4 research perspectives that I've set out. And like I said before, what we wanted to do was to encourage people to consider the sources of complexity surrounding an intervention before they decide on their research perspective. So then the development of research questions can be supported by this consideration and awareness of complexity, alongside information about what's already known and what the priorities are for the key stakeholders. So yeah, I think I said already, the kind of key questions are to think about what is already known and what are the most important things to find out. And just to highlight again that we're not saying that we should take one research perspective only, but that these things can overlap somewhat depending on how appropriate it is for the problem or intervention in question. Another reason for the update was to give due attention to intervention adaptation and also to interventions developed outside of research teams. So this is the framework that we came up with. So you can see the 4 research phases, fairly similar to the research phases that were used in the previous framework document. But over on the left there, we've got develop the intervention, and then we've added in or identify the intervention. So that's about choosing an intervention that already exists, either via policy or practice, and then exploring its options for evaluation. And we've also highlighted evaluability assessment, which is a process or method that can be used to bring in stakeholder perspectives on the evaluation design. And again, if you want to find out more about evaluability assessment, there's various links within the document. But it's a really useful method for getting different stakeholders together to develop their ideas of the programme theory, and then working out what data is required and where we might get that data from in terms of developing the evaluation. The other thing that we wanted to highlight was, which perhaps doesn't come across so well in the figure, but was the implementation phase. Throughout the document, we talk about implementation at all phases, so the importance of considering implementation very early on, because obviously if an intervention is not implementable, then it's essentially not much point in doing the research in the first place. Unless, of course, it's already implemented, then there's good reason to explore and evaluate the policy change or whatever it is. The next reason for our update was to highlight various important aspects of complex intervention research that are not always necessarily given due focus. So here we're talking about these core elements that we highlight in the middle of the framework figure. So I've spoken a bit already about context, programme theory, the importance of stakeholders, and the how essential it is to identify key uncertainties. I haven't really said anything about intervention refinement. So refinement is the process of fine-tuning or making changes to the intervention once a preliminary version or prototype has been developed. And that would be in order to optimize it. So between the different phases of research, there might be a reason to refine an intervention, either based on the data that's collected or because of how the programme theory has developed throughout the process. So we obviously want the optimal version of an intervention to be evaluated and implemented, and ongoing refinement can support that. If we consider refinement throughout, this can also improve the potential implementability of the intervention elements. I think acceptable refinement really differs depending on the research phase, but also the research perspective. So for example, in an efficacy evaluation, refinement of the intervention is discouraged, where it's really important that standardization and consistency of the intervention are prioritized in order to maximize internal validity. However, if we're thinking about from a systems perspective, adaptability and responsiveness of the intervention is expected and are likely to be a key focus of the research. The extent to which variation in programme delivery is desirable within an effectiveness or theory-based perspective really depends on the extent to which flexible form of delivery is allowed while preserving the key functions. And that's possibly something that should be considered in the early phases of the research. And we talk about having some criteria set out early on about acceptable refinement. In terms of economic considerations, we're really keen to include more on economic considerations within the document, and not just at the evaluation stage, but throughout. And as such, we have a few authors on the framework who are health economists and wrote the various parts related to economic considerations. So nearly all complex interventions will be costly to implement and will impose costs on a range of populations and or organisations. So inclusion of economic considerations helps us to understand the problem, helps to shape the design of future studies. So basically we just highlighted the importance of considering the economics early on. Okay, so what we've proposed here in our new framework might not be completely radical for many of the audience, but it is perhaps radical for some people who are skilled in sort of traditional hierarchies of evidence. From our BMJ article, Ray Posson, the kind of godfather of realist evaluation, described the new document as an almighty methodological shove in favour of pluralism in the evaluation of interventions. He had some criticisms of the document as well, but I will not go into too much detail on those right now. But I think just highlighting that it is a sort of shift in the way of thinking from the previous document to this one. As such, and in order to support the framework to be useful to people, we've developed a checklist for developing and evaluating complex interventions, which people can use and go through different questions and reflect on whether they have in fact covered each of the points there. So why do we have the checklist? So we wanted to provide it for researchers to help with the use of the framework, but also beyond that, obviously we need funders and peer reviewers to be on board, so they can use it to assess whether planned research is consistent with the framework's best practice, for publishers and reviewers to assess research quality, and also for evidence users to understand and use research. And these are the kind of phase-specific considerations. So within the checklist, we've got items related to each of the core elements, and also items related to these sort of phase-specific, or specific to the phases of developing, identifying, feasibility, evaluation, and implementation. If you want to look at the checklist again, it's in the NIHR Journals Library document, which I can provide a link to after this. So that was just a whistle-stop tour of the new framework, how we got there, and what we how we hope that it will be used. I just want to acknowledge our co-authors on the framework, and some other colleagues as well as participants who came along to the expert workshop and various conference workshops that we also kind of consulted academics at. The consultation and all the other kind of peer review process that we went through. Okay, so I'm going to hand over to Joe just now, I think.
So thank you, Kathryn, for this brief but comprehensive introduction. Right now, it's your turn.
Thank you, and thanks, Kathryn. I found it, having known the framework, a really helpful reminder. So yeah, what I'm going to do is talk for probably around 15 minutes, building very much on what Kathryn's just shared, really, to amplify some of the key points that we might want to think about in the context of nursing research and nurses doing research, really as a sort of potentially a prompt to bridge into discussion after I've finished. I thought it was worth, first of all, just reflecting on typically what within what we're trying to do in terms of building the evidence base for nursing and healthcare, just to remind us about some of the touch points, because I think that they provide a really useful framing for thinking about the relevance of the framework to what we're doing. So clearly we're very keen on ensuring that what we do is essentially person-centered in its focus in the research that we do. That typically it is founded very much on the need to address real-world problems and questions to ensure that we're giving the best care to our patients and the public. That what we need to do when we're thinking about the research that we do is think about the fit between what we're doing and the context of the practice. That we've got a mixture of nurses who are autonomous practitioners and researchers, as well as nurses who are part of teams. And as I mentioned just earlier, that primarily we're in our research endeavours, we're focused very much on improving the quality of care on that point of impact. So I think that in this respect, when we think about these features, the framework is a really good fit because it aligns really well with our intent and with our values. I also think it's worth just reflecting on, Kathryn talked to us about what complex intervention is, and I think probably, and I hope you would agree, that it's probably fair to say that most of the interventions that we would be interested in evaluating within our work could be described as complex. So I think, again, the framework provides a really good way in to thinking about how we evaluate those complex interventions within the real life world of practice. So the points that I thought worth amplifying just now are these ones, very much around this point of context, stakeholder engagement, the role of theory, implementability. And then I just wanted to reflect a little bit on what the framework might mean for us thinking through how we build research capacity and capability in a way that incorporates some of the principles of the framework. So to emphasize some of the points that Kathryn has already made, it's worth just reminding ourselves that it's certainly in my experience, and I'm sure in yours, the implementation of interventions may be both influenced by context, the context in which you're putting them into practice and evaluating them, and also affect context. And as Kathryn says, where we take a systems approach, context is also in itself not static. And you probably can think of examples from your own experience, but particularly drawing on the experience of one of the studies that I've been involved in, where we were trying to evaluate an intervention which was about facilitating the improvement of continence in care homes. The intervention itself was focused on improving both the context of practice, so the availability of resources, the culture of improvement, as well as obviously nurses' educational requirements for the clinical issue. But it was also focused on improving continence practice, so by implementing best practice guidance and influencing practitioner behaviour, to then hopefully improve the care and experience of residents. So what the framework enables us to think about is both the way in which our interventions might be framed by context, but the way that they also might be influenced by the context in which you're evaluating them. So it really helps us to guide us thinking about the important features of context we would want to pay attention to, and also how we might evaluate impact. So we're not only wanting to focus on the impacts of the intervention itself, but we're also interested in how the implementation processes impact and how they might impact on context. So the framework sort of opens up the possibilities around how we view context and how we take context into account in our evaluation efforts. And there's certainly, as Kathryn has said, greater attention to research approaches that are sensitive to context. Kathryn mentioned realist research, and that obviously is the understanding how things work in context and why is a central focus of realist research. The second area is stakeholder engagement, and of course, as nurses and nurse researchers, we're building on a very strong tradition here, because we engage patients obviously in our care practices, but also in our research efforts. But this is beyond patient and public involvement. It's very much around thinking about those stakeholders that we might need to think very purposefully about, that could be involved in both intervention, development, refinement, implementation and evaluation. And I think the point here is about how the framework points us to ensure that we have early effective engagement with stakeholders as partners throughout the research process. Now, this of course not only makes our research more relevant, but it also potentially could lead to more impactful research. So it's important for us to think about how our engagement with stakeholders will help us do that refinement process, both in terms of the development of interventions, but also the implementation of interventions, and think about how we can build in the formative feedback from our stakeholder engagement into our processes, into our research processes, so that we can not only ensure a better fit for our interventions within the clinical practice context, but also build on some learning which might help with implementation, actually through the research process, not leaving implementation until the end of the research process. So in this respect, the framework is helpful in signposting us to the importance of stakeholder engagement and how we might do that. Theory is another development, I think, within this framework, that it's a much more explicit as well as threaded focus on theory than the previous versions of the framework. So as Kathryn said, very much as a core element and as part of the evaluation approach. I think for us within a nursing research context, and actually I think more broadly within medical and healthcare research, arguably, we haven't historically paid enough attention to its theory, both use and refinement and testing. So what the framework encourages us to do is both develop theory and test theory, program theories, intervention level theories, as well as implementation theories. So a combination really of what we'd be very used to as nurses and nurse researchers, thinking about practical theories, you know, what's in our heads about how we think this intervention may or may not work, combined with more formal theories. So if we're thinking, for example, of setting up a new nurse-led service for pain management, we might want to start out with developing some propositions, which might turn into a program theory, or might lead us into a realist evaluation about how a service might be, how that service might be designed. It would be important then to talk to the relevant stakeholders about how they see the design of an impactful service, i.e. their theories about why a service might be impactful and what we should be designed into it, alongside referring to existing frameworks and theories. So, you know, you might want to draw on implementation theories, normalization process theory, consolidated framework. So where you combine the practical theory with the more formal theory. And I think it's important, theory, the prominence of theory in this framework, I think is important to us as a nursing research community, because it is one of those building blocks for building the evidence base for nursing. So I think that it's helpful to have this real strong focus on theory within the new framework. I mentioned implementability, as did Kathryn, and you know, as we know, for those of you who have done any evidence-based practice type work, we know that research and its use in practice, in nursing practice, is certainly not a linear process. It's very much determined with that link to context, that fit with practice, as I said earlier, and also with the views of stakeholder and stakeholder engagement. So it's really, I think, a really helpful step, and perhaps I would say that this because it's my particular area of interest, a really helpful step, I think, in this framework, that what we see is that implementation and evaluation are threaded throughout the research process, so that we can think about implementation strategies alongside intervention strategies. So if we're thinking, for example, about evaluating an intervention to improve the routine assessment of pressure areas, we could also include an evaluation of a particular assessment tool with an implementation strategy or strategies such as education and the support of facilitators or intermediaries. So it's a really helpful steer and fits really well, I think, with nursing and nursing research to have this focus on implementation, particularly given our intent on impact. I think it's also worth noting that the framework ensures that we're pointed in the direction of both intended consequences of what we do, those things that are anticipated and might be as part of our program theory as we set out, but also focuses our attention on potentially unintended consequences, which in my experience are those that it's certainly you won't have thought about at the beginning of the research process. And so finally, just thinking about what the new framework and some of the features of it really might mean in terms of how we build research capacity and capability with this sort of view and lens of complex interventions research in mind. So Kathryn used the word pluralist a number of times, and I think that is really helpful. It's helpful because it does provide a flexibility It does therefore mean, of course, that we need to have a really good mix of knowledge, of methods within our toolbox. It also means that from a personal expertise and sort of, I guess, experience and competence point of view, that we need to be able to therefore deal with complexity itself, but also with uncertainty. I think it also points us in a direction of needing to think about programs of research. I think it's easy, isn't it, for us to think about projects in isolation, but I think the framework does make us think a bit more about how projects might fit together into wider programs of research. There's definitely a lot of scope for methodological innovation, methods and methodological innovation. So Kathryn mentioned realist trials, so mixing different type of methodologies, combining approaches. I think there's potential for innovation around theory, development and testing. There's definitely innovation around systems approaches and perspectives. And I also think that there's potential for methodological innovation around health economics. We've typically been reliant on quality of life type approaches to health economics, and this framework enables us to open up a perspective on different ways of thinking about the value of interventions. I think also, you know, we are people who lead both unidisciplinary but also multidisciplinary teams, and the framework is inherently points us in the direction of multidisciplinarity. So when we're thinking about how we build our own capacity and capability, that idea of how we as nurse researchers lead multidisciplinary teams needs to be borne in mind. And I think overall, I'd say that how do we build in some of these features or all of these features into educational and development opportunities that we are part of and that we offer others? So I think there's some really useful things that the framework points us to that we could think about building into development and training opportunities. So all in all, I think the framework is a great fit, a really good fit for nursing research, because it offers us a broad framework. It offers us that sense of direction, but it does so in a way that provides us with some flexibility, which I think is certainly what we need within our field. And I also think it presents us with multiple opportunities for different ways of applying it, which again I think is really helpful. So Martin, I'm going to finish there, and I'm going to stop sharing my screen.
So thank you, Jo, for your thoughts from the perspective of a nurse researcher. We'll stop the recording now.